Okay, so let's talk about what you and I think about the DNS principle of functional joint centration. When we teach this at the courses, or a potential enemy talks about this online, they talk about the fact that there's no such thing as an ideal movement. There's no such thing as an ideal joint position. That even if there was, we wouldn't be able to tell it. We wouldn't be able to identify it anyways. So it's pointless in even talking about it. And then students, when they hear about functional joint centration, of course, have their particular questions as to what exactly it looks like, what exactly we mean. So, in our conversations over the past several years with the integrative assessment course, we've started to clarify, and I don't know if we expanded the definition, but I think we are starting to base the definition and description of this term from a neurologic perspective, which just makes everything a bit more consistent. So, what do you have to say about that? If somebody now asks you, what do you mean by functional joint centration? What do you say?
Well, I think that, first of all, Richard Alm gave an excellent description of the biomechanical factors that are affected by joint centration. Those factors need to be affected and minimized in order to spare the joint and to give it longevity over time. That's just pure physics. However, it is also the idea that when we look back at the idea of efficiency of a segment, efficiency of the body, we're looking to minimize stress. And the only way we can minimize stress, apart from simplifying the task, internally, the only way we can do that is to improve the way in which the movement is executed. In order to improve the way in which the movement is executed, we must give optimal afference to the central nervous system so it can make the best decision possible or available for that individual. Therefore, joint centration is a consequence of optimal afference related to the motor output. Yes? If we have a joint that gives the best information to the CNS, then the motor expression is the best possible that can be decided by the CNS at the same time. So I would say that joint centration then becomes a question of a neurophysiologically optimal strategy or relationship within the joint that gives the best afference for effective and efficient motor use of that joint. Does that seem to make sense? So
yeah, I mean, I guess, yeah, go ahead.
So we cannot, as was demonstrated, we cannot tell from position if a joint is centrated. We may suspect from a malalignment or our experience that a joint or segments involved are not centrated, but we cannot tell without inspection. And this inspection goes back to what do we expect when a joint is centrated?
Well, hold on. Let's clarify, because when you just use the term inspection, that immediately, to my mind, brings up visual inspection. I'm going to look at the joint. I'm going to look at the position to verify whether or not it is centrated. So what does Robert Lardner and Bill Tortoriello, how do we interpret inspection?
Inspection means assessment.
That's right.
If we have a baseline assessment, which means we go back to old principles. Yonder spoke about it. It's been part of the medical
I think it's
knowledge.
pronounced Janda. Janda, is that correct?
No. you, you really are going to stop that today.
Lewitt and Janda, I've heard of those guys. They're great guys.
That's right. Yes, Yonder spoke about it. And this is it. When we have problems with a degraded afferent input, we can see loss of range of motion. We can see loss of strength and force production. We can see an increase in nociception within the system. And there are other physiological factors, tendency to inflammation, edema, and as you remember, we used to look for changes in blood flow. So you could have redness or lack of blood flow to the area. So that is something else. And there are, of course, many other physiological markers that might be used but are not easily accessible in the clinical setting when you're with a patient.
Yeah, I mean, even, deep tendon reflexes.
That's right.
To be able to grade them.
That's right. So we have to find easy factors that are evidenced by the ideal relationship or status of a joint. And so if we inspect the person and we map we collect the basic data of these factors, and then we have them move, we can only, by inspecting them afterwards, confirm if the movement has been efficient or not, by either an improvement in these markers or a status quo for these markers as a measurement of how well integrated the afference, processing, and motor efference is. Yeah. That is really what we are left with.
Yeah, well, as we have been talking last week, this past week in Prague and over the past several years, it's unfortunately, I think we made a category error. We made a category mistake, and we didn't realize we were making the mistake. And that is, when we were talking about joint centration, we were so concerned with the biomechanical principle as well as the kinesiologic effects of, quote unquote, poor joint centration versus ideal joint centration, that we got so caught up with the biomechanical speak and the kinesiological effects that we forgot that we're not fundamentally talking about a biomechanical principle. We're talking about a neurologic principle. And as you just described, the neurologic principle of joint centration, the importance or the quality isn't about necessarily the actual joint position. It's about that joint position's effect into the central nervous system, or afference into the central nervous system, and the motor and the output as a result of that afference. And if we kept that kind of neurocentric perspective, we would have immediately saw that the only way to identify and confirm whether or not someone is using a centrated joint, which AKA is kind of synonymous with an ideal quality pattern. The only way to determine if the pattern was in fact ideal is to measure the objective neurologic signs after they did it. That's the only way. Because we admit that the biomechanical principles, you can have norms of orthopedics and biomechanics that says when a shoulder's in this position, generally speaking, among the population, it's in the better position. But when you have the individual on the table, you cannot apply the norms to the individual.
No.
Therefore, when you look at a picture or you look at a video, you can't make a real clear statement, a declarative statement about the ideal quality of that movement just simply based on the visual inspection of the biomechanical principles of the picture or the video.
That's right.
You can get a good guess
You
because
can
there
get a good
do
guess.
exist norms, but
That's
you
right.
can't definitively say. And that's where the category error comes in. Because as soon as you throw the picture up, you've already made the category error. You said joint centration and ideal movement is about fundamentally the biomechanical principle, and it's not.
Mm-hmm.
If you
Yes.
enjoyed this conversation and want to hear more like it, then please like this video and subscribe to our channel. You can also stay up to date on our latest seminars on our social media pages on Instagram and Facebook at IMTR Seminars.